right, today we are going to first start out. Does anyone have anything that they want to talk about that's new or going on? We don't have a case to present, so if anyone has anything that they would like to discuss. No. All right, so we will go ahead and get started. All right, Kelly, whenever you, oh, I guess I should screen share. Sorry.
That's okay. If you need me to try to pull it up, I can. Do you want me to do it?
Nope, I got it. Thank
Okay.
you, though.
No, you're welcome. Hi, everyone. It's a small group today. So I found out last week that I was presenting today. I didn't remember, so it was nice to get the reminder. So the topic is family therapy and group therapy with children and adolescents, and that is such a huge topic. I mean, we could take a week on each one at the very minimum, right? So I was just trying to combine it and look at it from the perspective of working with children and adolescents, because that's who I work with. And I work with some young adults, and obviously both family and group therapies, are important for working with adults as well. So, okay, go ahead. There we go. So I just recently, within the last couple of weeks, meeting with a lot of families where kind of the socioeconomic status is really a concern. This is not necessarily related to family therapy or group therapy, but it is. I think remembering that when we are working with our families, we need to be cognizant of kind of where they are on that economic, ladder, and if they're having any basic needs, they have issues with basic needs, and we need to make those referrals to resources in the community before we can even begin any of the individual or family therapy piece of it. So just wanting to review just quickly, everybody knows this, it's Maslow's hierarchy of needs, but just looking at those bottom two, those foundational issues of safety, physiological safety, and having food, having shelter, because we do have we've had several food insecure families present in the last couple of weeks. So just being aware of resources in the community, and if that's something that folks are interested in learning more about, we have an incredible intern, Abby, who just seems to know everything possible out there. So we can ask her to join us, for one of these sessions to review that. She did a training for behavioral medicine, and it was just incredible, and she just knows everything. So alrighty, so that's just a quick reminder of being aware of that. Okay, so when we're looking at kind of family therapy, group therapy, individual therapy, we want to take a look at what's happening currently, right? What's happening in our society. So 1 in 6 children aged 2 to 8 years of age, okay, I repeated that, age 2 to 8 years, they have a mental, behavioral, or developmental disorder, or layers of these issues, right? So we're trying to tease through all of that to try to improve the functioning and the mental health of the children that we work with. And when we're working with kiddos, right, we don't leave the parents out. Parents have to be a part of it. If I hear like a therapist who's working with children, they don't invite the parent in, I'm wondering why, because that needs to happen, right? And that parent is kind of the main model, the caregiver. And typically when we see kiddos presenting with issues, we need to look at the parents, right? Because a lot of times it is the functioning in the home or the dysfunction in the home that's creating that behavior. Okay, next slide, please. Thank you. as we know with COVID, we saw so much happen with COVID. And as the statistic reports, we saw a 24% increase in the proportion of mental health emergency department visits for children ages 5 to 11. Okay, and I want us to, and for kids who are 12 to 17, a 31 increase. And I want us to think about that for a second. An emergency room visit. That means those kiddos have gotten to the point, either with their depression, their anxiety, or whatever they're struggling with, that they had to present as suicidal or homicidal, right? To get to the emergency department and to present that the depression or the anxiety was so severe that they may have been on the verge of those things. So, so just thinking about that, and the total percentage of increase, right, in those numbers. And, you know, COVID was particularly difficult for children and adolescents, but with the younger kiddos, because it was essentially 2 years, right? We were, you know, in our homes looking at each other on the computers like today, right? But so kids didn't get to connect with other children. They didn't get to play with other kids. They didn't get that exposure, right, to like a pre-K setting, to that structure. So unfortunately, a lot of kids presented, you know, shortly after COVID, looking like they had a developmental delay or maybe autism or maybe, you know, something else, when it really was the lack of exposure and learning how to regulate their emotions. So we did see a big increase at that time. Okay, next slide, please. So this is just looking at the age groups and depression, anxiety, and behavior disorders. You know, depression can look so different in kids. It can look like anger, right? Angry outbursts. And it can look like isolation. It can look like sadness, kind of typically what you think of with depression. But what I'm seeing a lot and have seen the last couple of years is depression is presenting as, you know, kind of that verbal aggression and physical aggression. And we're seeing it a lot more in girls than we saw before. So it's really interesting how that's presenting. All right, so the same thing with anxiety, and then behavior disorders. You know, behavior disorders, chicken and the egg, right? You're looking at, does this kiddo have a history of trauma? Does this kiddo have depression, anxiety? Does, you know, and is that why we're seeing these behaviors? Is there a developmental delay? So many questions that we have to investigate with that. So I'm kind of going over all of this before we get into the family therapy piece, just to underscore the increase in numbers that we're seeing with kids with depression and anxiety at younger ages, right? And sometimes parents just, they don't know what to do, right? They don't know how to support that. They don't know how to engage with their child. So hopefully they reach out and seek assistance. Okay, next slide, please. All right, so obviously, like I said before, with family therapy and group therapy, we could spend days on each topic. So I'm really just giving a really brief overview of the different types of family therapy, and then kind of talk about how it kind of looks like in real life, right? I don't know how many of you are clinicians and that you see families. I am not a marriage and family therapy specialist. I am a clinical social worker. And so in my practice, I kind of pull from different strategies and try to incorporate those strategies in the best way to meet the needs of that family. Okay, so I'll just kind of briefly go through this. The functional family therapy. So they're looking at the family dynamics that have contributed to the problem behavior of the identified patient, right? Usually it's it's the kiddo who is the identified patient, you know, oh, they're horrible, if they would just do this, if they would listen to me. So what this approach does is takes a look at that whole family functioning, and most, you know, obviously family therapy does, but you're looking at how each person, right, is contributing to that dynamic that's creating that behavioral issue or you know, the emotional dysregulation or the depression or the anxiety, and how changes in that structure can really improve, you know, the outcome for the child. Marriage therapy, I do not do. I will be very honest. Nope. That's not one of my areas, and I leave that to the licensed marriage and family therapist. That's outside my scope. So, but obviously very important for understanding, you know, that relationship between the parents, the mom and mom, the dad and dad, the mom and dad, whomever it is, right? That relationship and how that relationship is either supporting the kids in the family or not, right? And what they're modeling for the kids. Strategic and structural family therapy are similar in their approaches. And, you know, we have, some of you may know, I don't know if you've studied this, but Salvador Minuchin. And what I particularly like about him, he was kind of sort of the father of the structural family therapy. And what I liked about his research in the beginnings, and this was probably back in the 50s, I think 50s and 60s, and he he was working with kiddos who were from the inner city, and they were at a treatment center, kind of outside of their normal environment, and they would do well there, right? And problems would decrease. However, nothing was really coming to any kind of resolution, right? And kind of what is the underlying issue for that child. And he realized we need to involve the family. We cannot work with the child alone. Now, sometimes, unfortunately, there may be settings, if it's, you know, inpatient care and you don't have the participation of the family, then that, you know, there are only so many things you can control for. But for any work that's done with a child or adolescent, the family has to be a part of it, because that is, we can work with the child and get them really strong, right? Because I did work inpatient care at Sandy Pines Hospital down in South Florida, and I worked there for a few years. And what we would see, unfortunately, is that, okay, we could get that kiddo nice and strong and deal with those issues and start the trauma work and do some really solid work with that kid. But if we didn't have the parent engagement, and we didn't have the parents, you know, either attending virtually for family therapy or coming in person, it was almost like you get an ice cube, right? Nice and frozen, hard and, you know, really frozen, solid, very solid, right? It was almost like putting that ice cube into a bucket of water, and that family was the bucket of water. And so eventually what happens, that ice cube melts and just melts back into the water, and the same dysfunction continues unless you engage the family. Is that easy? Nope. It is not. First of all, with a lot of settings, just getting parents in or even virtual is difficult. If you have folks who, you know, are working several jobs, and, you know, if they take off work, it means they can't pay their rent or they can't buy their groceries. So it can be very difficult to get the families involved. But I think what I find in working with families, bringing parents in, you know, I try to join with them in saying, you know, your child best, you know, I need your help, you know, to be able to help your child. And then what can we establish in the home that's going to be supportive? How do you respond to your child? How do you give direction, right? How do you show love and support? Is it what the child needs? And oftentimes you will find that kiddos are pretty good at sharing, you know, how they would like their family to be, how they would like that construct to be. So, but it's a difficult line to walk, because, you know, you have to join with the parent, because if you don't, and kind of, if they decide that, you know what, this isn't for me, then you're not going to get anywhere with that kiddo for long term, you know, for long term. Okay, next slide, please. All right, so the benefits of family therapy, right? So after participating in family therapy treatment, 90% of people reported an improvement in their mental health, 66% an improvement in their physical health, So we're like, wait, how does that work? But we all know that our emotional health and our physical health are connected, right? So if we're having a lot of dysfunction in our home, if it's very toxic, if there's a lot of conflict and fighting, that is of course going to impact our physical well-being. Okay. 73% of parents report that their child's behavior improved, and better functioning at work or school. So if like a kiddo was older, an adolescent, like if they were possibly working, also and going to school. So again, I can't emphasize enough the importance of bringing the parents into the process. In most cases, when you bring in the parents, you look at that construct and you kind of identify, okay, what's happening here? What is kind of enabling this behavior of the child, or what is creating this behavior? Because sometimes it can be. I mean, I had a parent in, it was a couple weeks ago, and I hope everybody's okay with language that I'm just quoting here. So she called her 9-year-old daughter a bitch because her 9-year-old daughter was having some anger and agitation about just many things happening in her life she had no control over, and that probably would make anybody angry, right? So this parent really needed to learn how to, step back when she's feeling angry, right? Step back, think about how she wants to say this in a way that's going to help that child learn and to grow and develop from that, rather than just stopping her. Because imagine how this little girl felt, being called this name by her mom. So she was already angry enough. So this is just going to add to it. So, and I'll honestly say that I think a lot of parents just don't understand. They don't understand how big their impact is when they're being critical, or they're using, or they're being demeaning to their child or derogatory. I guess I want to believe that they don't understand what they're doing. So our role is to try to help them to understand that and to make those changes, and using family therapy in whatever way we can. If it's one parent, if it's, both parents, if it's all the kids and everybody, I think eventually in working with a child, you do have to bring in all the members. So, I just can't emphasize that piece enough. Okay, next slide, please. Group therapy for children and adolescents, right? So what is so wonderful about group is that it really connects kids to other kids who are facing similar challenges, right? Sometimes it's hard to get adolescents to join a group because that's typically not what they want to do, is sit in a group full of, a group of people and talk about their issues. But it can be so helpful because they can understand that others are feeling the same way, and it helps them not to feel so isolated, right? And it gives them a resource to understand, what they're feeling, how they can express that in a more healthy and positive way. Okay. I'm not going too fast. I feel like I'm talking really fast. I love this slide because this is your brain during adolescence. And that's really, it's really what we're seeing, like so much of the emotions and not being able to regulate that and responding to that initial, angst or anger or sad, whatever the feeling is, and not being able to regulate that. So in group, we can really work to hone those skills, right? To learn those skills, to hone those skills, and then to practice. That's the best part of it, right? Because you can have a kiddo, an individual with you, and you practice these things. You talk about, not being aggressive when you speak, and using, assertive language and social stories, everything that you do, right? But having that group process that allows them to actually practice those skills is so beneficial, so much more beneficial than I think just learning the skills solely. So, okay, next slide, please. All right, so over the years, I have facilitated many different groups. I had a program in South Florida where I would involve the social work interns, MSWs and BSW level, they were interns in our school, and we were able to facilitate a number of groups to address various issues. And it was almost, you're kind of providing that universal, intervention to kiddos. And then kids obviously who we could identify from group might need a little bit more, then they were referred to individual therapy. But I think that's such a resource to have in schools. And anybody who knows me knows I talk about schools a lot, but that, we have those kids in school for 7.5 hours a day. And the more we can kind of flood that system with mental health supports for kids on various levels, from groups to individual, I think is the direction that we really need to go, considering the numbers, the percentages of increases in anxiety, depression that we saw at the beginning of the PowerPoint. So I worked at an elementary school, so we had the awesome group. So we focused on kiddos with ADHD and how they could develop that regulation and how they could interact better, in their classrooms, being able to focus, teaching them how to focus, how to, kind of bring it back once they've lost focus. And we would, connect with the teachers too. So we could really interface with the system and see how, what they were demonstrating in the classroom, provide the group, and then see how that, how that benefited them, or if it did. So we had, there's just so many different topics that really anything like anxiety, the worry warriors, trying to start that here. I think I have a group for summer, so I'm so excited. And it's really teaching kiddos how to understand their why they get upset and out of control, related to kind of that executive functioning, and also, the learning about our amygdala and what it does, so, and how we can control it. So I just think for kids, particularly like elementary kids, if we can start and be consistent with that group, that age group, then it just builds as they get older. Okay. Obviously, like depression, emotional regulation, the dialectical behavior therapy group. I think it would be great if one time we could bring Kristen in to talk to everybody, Kristen Boyce. She provides a group here, and particularly I think it's helpful for adolescents to really learn how to manage their behaviors and how to not be so consumed with their anxiety or their worries. Mindfulness, movement, not like a movement like woo, but having kids move, right? We would have yoga groups, but we had to call them mindful stretching groups. And it was incredible to see the difference when the kiddos would come in, and we would then do the yoga, the mindful breathing and mindful stretching, and then we would use the doctors out there, I always forget what this is called, the oximeter, am I saying that right? Measures your, am I saying, I don't know, but it measures your measures your heart rate. And so we would measure their heart rate when they came in, right? And then measure after yoga, and you would see a pretty good decline, like 5 to 10 points. So then the kids could see that too, and they were like, oh, this is so cool, this really does work. It's like, yeah, here's the proof, it works. So that was really cool. Do you want me to pull up mine? Okay. So other groups, again, with groups, you can be so creative and really look at the needs in the particular, either the agency, right? Like here, the Worry Warriors, or in schools where, you can find out like what is needed. I'm going to be careful how I talk about this one, because in Florida, if anybody's familiar, it's pretty conservative with things down there and what you can talk about in schools, right? And thank you, Kelly. And so we would call a group a healthy relationship group, right? You're learning how relationships are healthy, because we would have 3rd, 4th, 5th graders coming up to us with lots of questions, right? About, gender identity, different things related to that. And in that state, you weren't allowed, in this last year in particular, you weren't allowed to talk about that, don't say gay, all that stuff from there. So we would have this group and have this group available and entitled Healthy Relationship Group. And then the kiddos could talk about whatever they needed to talk about, right? So they would have that safe space to talk about things. Okay, we weren't promoting anything. We were just giving the kids a safe place to talk and to share and to receive support. The last group we had there was the newcomers group, which was one of my favorites because the school was probably about 80%, maybe 75 to 80% of kiddos who were undocumented immigrants and very new to the country, like coming in, not knowing the language, everything. So we would have several newcomer groups for different grades. But I gave these examples because that's the amazing thing about group, is that you can be so creative with it for whatever is needed for your population, your agency, your school, whatever it is. And you can create that for the kids, right, and adolescents. And so they have a place to share, and they know it's confidential, and they know that there's no judgment, and they can talk about whatever it is they need to talk about. Okay, next slide, please. All right, so this is so thinking about resiliency in children, right? We want to build that resiliency in children and adolescents. And with parents, learning how to provide controlled choice, right? When controlled choice and meaning that they give their kiddos, so they empower their kids to make choices. Parents are okay with both choices, but the kiddo gets to make the choice, so they feel empowered, they feel confident. You know, they feel like, okay, I can do this, right? But also at the same time that the parent needs to really provide that structure, the boundaries, the limit setting, so that child feels safe. That's what I work on a lot with parents in our sessions, is being able to create that environment where their children are heard, but there's also, you know, this is what you can do. This is not what, you know, what you can't do, and you need to make a choice about your behavior. And I am here to support you, but I'm also here to help guide you in that way. I think, you know, from what I've seen in the last couple of years, I'm seeing parents that are either way too lenient, right? They're just not giving any instruction, not giving any direction, nothing, to parents who are just, you know, when you think of helicopter, you know, parent, that's what they're, you know, that's how they're managing their family. So, and once they make a few changes, it's incredible. They're like, wow, you know, I didn't realize that this could make such a difference. And it does, you know, because the kids need to know that the parents are taking care of them. They're there for them. They're taking care of them. They're in charge. And so that way the kids don't feel like, okay, the adults don't know what they're doing. So that means I have to take care of this. And what is that? So, so that's why it's just so important to involve the families, the parents, caregivers. Okay, next slide, please. Oh, I love this quote. Anyone who does anything to help a child in his life is, or her life, or their life, is a hero. I love Mr. Rogers. So next slide, please. Any questions? I know it's kind of quick. I think I was talking really fast. I apologize. I had an extra Starbucks today. So.
Hey, Kelly, this is a great presentation. I can't share your need for family therapy, especially the younger the child, is such a critical component. I think on my end of things, it is so often what's the missing sauce of why people aren't getting better. And what I wanted to ask you about, and again, my experience is pretty limited to the South and Appalachia. I trained in North Carolina, and most of the people I know are in the southern place, and so I don't know much about maybe other, but I at least in the Appalachian culture, that failure for families to recognize their power and their importance, to me, just feels like very cultural. And I know you came from Florida, and it was kind of interesting to hear you say that in Florida as well, because it is so hard to get buy-in around here. And I sometimes struggle with how much of it is that, you know, it is an Appalachian culture around here with lots of ACEs, a lot of intergenerational trauma. So there's a lot, I find a lot of caregivers
in this region have trouble buying in because I it's like they're struggling with their own self-care and own self-worth to see that, and many times suffering the same sort of problems that the child is. It's almost like a send it away wish to be fixed instead of fixing it in the moment. And I was curious. I was just curious. I haven't really looked at the concept of family therapy buy-in in a cultural sense or an Appalachian sense before to even say whether that is, you know, a global thing or not. But I just wondered if you had any thoughts on that cultural piece, and if maybe we're seeing a more isolated spot. I don't hear that being said when I go to national meetings, though. I mean, I you know, it's they seem to always talk about the importance of family therapy, and I never hear that. So when you said that happened too in Florida, I wondered if you've seen any of that, because I mean, it is so hard to get buy-in, and I'll also say I think a little bit even practitioners, it's a little hard to get buy-in for that in this area compared to other areas. And I don't know if that's because they get pushback from the parents or it's just a different individual focused approach. I don't know, but I'm just curious about your thoughts about that.
Okay. And yeah, and you know, I do see I did see similar things in Florida. I worked in a lot of different areas in South Florida. I worked out west, which was like the rural kind of the sugar cane being grown out that way. And then I worked all over the county. It was a huge county, lots of different folks, a lot of diversity, which we know we really don't have here. So seeing kind of similar issues across the board in working with Haitian American families, Mexican American families, you know, the families of the kiddos who, you know, are from Honduras and from the undocumented kiddos, in that. And then it was really, I think it's pervasive, right? I think that, and now we're seeing with so much happening with social media, and I don't want to get on that that's soapbox, but so with social media and you know, kiddos with the video games, all that stuff, and parents are, you know, you have parents who work 2 or 3 jobs and they just can't supervise like they should, right? It's not a like I don't want to do it. It's for some parents it's like I can't, I just don't have enough, I need to clone myself to be able to do that. But I think we do see that across the board. So yes, it's may look just a little different in each area, but we're seeing parents either just not parenting, like, okay, and letting this kid do whatever they want to do and they think that's okay. And then parents who are just, you know, obviously very strict, and then to the other degree of being, you know, abusive. So so yeah, I do see that across the board, even in, you know, South Florida. I also worked in Michigan for a little bit, saw it there. So it's just I think also with practitioners, your point about practitioners, it is hard to face the family, right? It's easy, bring the kid back, you do whatever you're gonna do. Okay, there you go, you know, go back out to the parent. But it's a fine line too of like maintaining confidentiality, right? Because everything that kid talks to you about in that room is confidential, except the, you know, the waivers of confidentiality. But so being able to share with the family what you're doing, what you're working on, and then how the parents can support that. And I think a lot of practitioners are scared of that, quite honestly. It's because it is you know, you're facing this adult who may not agree with you. And I think, again, just trying to join with that parent and saying, you know what, you know your kid best. Let's talk about this. Let's figure this out, how we can all work together to make this better. So whatever's presenting, you know, in that home or in school, that we can look at, and you can help support the changes that we're making, you know, in the individual work through the family support. But I do think it's scary for a lot of practitioners. And I do hear that. And I have to say that is different up here because, you know, it's just it was at least commonplace that you bring the parent back, you find out what's going on, what happened this last week, you know, okay, did you try the strategies we talked about? So you do like a check-in with the parent, you meet with the kid, and then if you need to, you kind of bring everybody back together at the end, if there's anything else you need to review. And that was commonplace, but I have noticed up here, you know, that piece doesn't always happen. So, and with kids, with young kids, but also adolescents, because I work with several, and that family piece is crucial, you know, because adolescents can be, they can be a little tough. So I hope that answered your question. I don't know, I felt like I was rambling. I'm sorry.
It did.
Lauren,
And
I taught public education in a high school setting in multiple different counties, and I feel like you could almost feel a sense of difference even in like counties that were next to each other on just the culture and how stuff would be handled. So I think it is very common that it is around like in this area as well. Does anyone else have any more questions?
Thank you. Thank you so much for listening. I appreciate it.
Well, thank you for presenting and all of your really good feedback. The next meeting will be on will be on June 5th, and it's going to be on workplace violence mitigation for healthcare workers. It's going to be presented by Sandy Brundage, which is an OM resident. If you guys have any questions or need anything in the meantime, feel free to shoot me an email. And if anybody has a case that they would like to share and present next time, you can email me or get on RedCap and submit that. So thank you all. Have a good rest of your day. Thank you, Kelly.